Christy Hallett is a board-certified pediatrician, pediatric emergency medicine physician, and current medical toxicology fellow at Emory University, Georgia Poison Control, and the Centers for Disease Control and Prevention. She obtained a dual Bachelor's of Science degree in biology and chemistry from Texas Lutheran University in her hometown of Seguin, Texas. Dr. Hallett found her passion for treating sick and injured kids while attending medical school at Baylor College of Medicine in Houston, Texas. She returned to South Texas to complete her pediatric residency at the University of Texas Health Sciences Center at San Antonio and became chief resident. Dr. Hallett recently completed her pediatric emergency medicine fellowship at Vanderbilt University Medical Center in Nashville, Tennessee. So without further ado, it's Dr. Hallett. She's speaking on pediatric COVID and MISC features, diagnosis, and recommendations.
I'm predominantly a pediatric emergency medicine physician. I am not an infectious disease doctor, but I see a wide range of COVID-19 presentations in children, and most require just, symptomatic care at home. But I have seen really, really terrible cases that required ICU level care. Again, I'm Christy Hallett. I'm a med tox fellow right now currently, but I also work as an emergency medicine physician, so I'm still practicing. And y'all know my affiliations. So disclosures, I have no financial conflicts of interest to disclose, unfortunately. Some of the objectives is to describe clinical features of COVID-19 in the pediatric population, compare laboratory findings consistent with multi-system inflammatory syndrome in children, diagnosis, and then summarize the management recommendations for a child with COVID-19 infection. This is my introduction. These are just kind of a few things that we'll hit on. The epidemiology, clinical manifestations of COVID-19, the diagnosis, multisystemic inflammatory syndrome in children, the treatment, and prevention. And let me know if you'll have questions in the middle of it. I created a lot of time afterwards for Q&A as well. But if you have questions, feel free to just either put it in the chat or just speak out. So epidemiology, children of all ages can contract COVID-19. The youngest I've seen is a 3-day-old, like newborn baby who contracted it from mom. There's about more than 1.2 million positive tests of COVID-19 between March and December 2020 in children less than 18 years of age. Children of underrepresented racial and ethnic groups are disproportionately affected by COVID-19, hospitalization and death. I get all my data from the COVID website from CDC. They keep the numbers from a state level and federal level, or state and national level, updated weekly. So we know that COVID-19 has affected all ages, and we're kind of coming down from a second wave. We've had, or pretty much a third wave, sorry. It's as bad as the initial one this year. And these are numbers of admissions. So if you can see that this is numbers from kind of a little bit before October 2020. Can you all see my mouse cursor?
Yes, we can.
Okay, great. So we saw this kind of big spike in the winter time, and then we saw a spike again kind of when school started. But if you can see, this is of all age groups. But what you see is the hospitalizations in the 0 to 17 years of age kind of increased this past fall, or past like late summer. So clinical features of COVID-19 infection, fever, kind of respiratory symptoms of cough, congestion, rhinorrhea. Kids can have sore throat, they can have difficulty breathing, abdominal pain, rashes, nausea, vomiting, diarrhea, fatigue, headache, body aches, myalgias, loss of taste and smell, feeding. If they're less than 1 year of age, some of the things that can clue you in is a child that won't feed well. So kids have to, under the age of 1, if you notice, they'll breathe out of their nose while they're eating. If you can't breathe out of your nose while you're eating, you have to make a lot of pauses. And so you may not be eating as well as you would or for an infant, or making enough wet diapers. And then also kids can be asymptomatic, right? So from all these kind of features, like, how do we know? Is it COVID? And that's kind of the hard part for the clinician to say, is it COVID? Is it not? I'm not sure. So any symptom listed could heighten your suspicion of COVID. And then you should ask about close exposure. So parents, grandparents, and a lot of times kids live in these kind of multi-generation households where there's, extended family, aunts and uncles who live in the same household. A lot of families got displaced because, they couldn't find work, or so they moved in with each other. And so that's why you're also seeing some of this disparity in kids who come from low socioeconomic status, that they're just getting exposed, and they can't have the luxury of not going to work. So they're getting exposed in the workplace as well. Friends, especially if you're in the teenage population, boyfriends and girlfriends, and then also they just like to hang out with each other. Who should be tested? So the criteria for testing is dependent on geography and the availability of testing. So you have guidance from CDC, the American Academy of Pediatrics, and the Infectious Disease Society of America. So outpatient testing, so any like clinics and sometimes in the emergency department, any child with an underlying condition with increased risk of severe disease, children with known in-person exposure with a confirmed case of COVID-19 in the past 14 days. If you have a presentation of severe illness, so if you have a kid with having difficulty breathing, we're going to test them for COVID. And then to go back to school and to go back to the daycare as a precaution and an epidemiologic standpoint, we like to test them so that they can be cleared to go back to school or to daycare. Inpatient testing is based on the hospital's recommendations. So where I trained and I just finished my pediatric emergency medicine fellowship, we tested everyone who was going to be admitted, whether or not you had symptoms or not. And it was a way of infection control. So everyone who was anyone that tested positive would go to a separate ward, and it's an ICU level ward, but depending on the nursing ratio is how it was defined, if you were a floor status or an ICU status. And your specialist or your person, their primary team, would go to that specific floor for management of the patient and to see them daily. It's a little bit different here in Atlanta. They don't have widespread universal testing except for those who are going to go to the hematology oncology floor, and then also the ICU. So what are laboratory testing that's available? There's the nucleic acid amplification test, or the NAATs, and we also just call it colloquially PCR. It detects specific region of genes. It's highly specific. So you're looking at certain region of genes for COVID-19, and if it's positive, it's positive. Rapid antigen tests are less sensitive than the PCRs, but it's highly accessible and you have quick results. These PCRs are costly. They can range from like $300 to $1,000. The rapid antigen test, you can buy one, I think, at CVS or even at Walmart for like two for $30. They're less sensitive, they're highly accessible, quick results, they result within the hour. The PCR, it can take, depending on the batch that the lab does, can take anywhere from 3 hours to 24 hours. If it's a positive test, it equals disease in a symptomatic patient. So you have to kind of look at the whole picture for the patient. If it's a negative test, it could be a false negative or a true negative. And then serology. So the first two are nasal swabs. You kind of we call it, for the kids, we're kind of doing a little brain biopsy. You have to get kind of deep down in there, sorry. Serology antibody testing is with blood, and it can diagnose prior or late infection. So you have to have at least 3 weeks, and then it tests for IgG levels against COVID-19. So reinfection cannot be based on PCR alone due to the possibility of prolonged viral shedding. So if I have a kid that, a month ago had COVID and was tested positive, and I test him again, I can't say that this is a reinfection. So we would have to repeat consideration of a reinfection is if you have a positive PCR greater than or equal to 90 days after the initial infection, regardless of symptoms. So you kind of have like this kind of clearance period. And then you can have a repeat positive and between 45 to before 90 days after the initial infections, and then have symptoms that's consistent with COVID-19. So risk factors for severe disease of COVID-19. So medically complex patients, kids with cerebral palsy, kids that are wheelchair dependent, any kids with genetic conditions, kids with seizures, neurologic conditions, metabolic disorders. So if they require special diets or they can't do any prolonged fasting, they'd be at risk for severe disease. Kids that are born with a congenital heart defect are at high risk. Obesity, diabetes, those are immunosuppressed or are patients that are on the hematology oncology floor, are pretty closely watched. And then those with asthma or other chronic pulmonary diseases. So kids, like if they are NICU babies that are on oxygen, they have BPD, are at risk as well. They just don't have as much reserve, and so any hit to them can cause a severe disease. So MISC is multisystem inflammatory syndrome in children. It was first described in a set of children from the United Kingdom after their initial infection of COVID-19. So MISC is not the same as a severe disease COVID-19. This MISC can show up like a month to a few months after your initial infection. It's a serious condition that can be life-threatening that occurs like post-acute infection, and features are similar to Kawasaki's disease. So Kawasaki's disease is one of like the bread and butter diagnoses for pediatrics. It includes like a strawberry tongue, a rash, desquamating fingers, edema to the hands and feet, and it's also hallmarked by at least 5 days of fever. It is an autoimmune disease that attacks the medium-sized vessels, and so the biggest vessel, the most worrisome vessels that it attacks is the coronary arteries and veins. And so what happens is these kids can get dilatation of their coronary arteries, and require something called IVIG. And so these are like outward symptoms. MISC is very close, looks pretty close to Kawasaki's disease, except we use a criteria to like think about persistent fevers is 3 days. And then they have GI symptoms. So sometimes they could have nausea, vomiting, abdominal pain, and it can also appear like they have appendicitis. And then rash, they could have inflammation of their heart tissue, and then increased inflammatory markers like ESR and CRP. So these are, this is from the CDC. And so these are cases of MISC and COVID. So COVID, you see that these are peaks, and then a little bit lagging behind are peaks of MISC. So MISC by age groups, it kind of hits the 6 to 11 years of age, but you can also notice that it hits all pediatric populations. It affects boys more than girls. So girls, we get something. Laboratory assessment of MISC. So it depends on the severity of the clinical presentation. If this kid just kind of looks a little puny, we can consider like a CMP, CBC, and a CRP. Now, if a kid is really sick and appears in the emergency department, we're going to get a slew of labs, CBC, CRP, ESR, a ferritin, which is another marker of inflammation, an LDH, which can show us some hemolysis, a CMP, a urinalysis, and then also cardiac markers of BNP and troponin. We'll also get an EKG and an echo as well, with a chest x-ray. And then we could obtain other labs to rule out other infections. So if they're having altered mental status, we can consider like meningitis, or if it's a child with a really high fever that's uncircumcised, less than the age of 1, or they have risk factors for UTI, we can obtain urine cultures as well. And then our PCR has COVID plus other respiratory viruses, like the flu, other regular coronaviruses, rhinovirus, see what else is on that thing, paraflu, and then also some other respiratory infections like mycoplasma and pertussis that can be also tested on the PCR. So treatment is really, the cornerstone of it is symptomatic care. So when a child comes to the emergency department and tests positive for COVID, they have to meet some home criteria, some discharge criteria for me. So they have to be able to maintain their hydration just by drinking. There's no need for supplemental oxygen, so they can maintain their saturations on just regular room air. They need to be able to walk on their own, and they should have good follow-up. So just because I see a patient right now doesn't mean that they can't get worse. So I always have a follow-up with their pediatrician for at least 2 to 3 days, depending on my clinical picture of the patient. Now, if it's like an infant and they're like on day 2 of their illness, I may say you need to go to your pediatrician tomorrow. Most respiratory diseases will get worse between day 3 and day 4, and then they get better. So if I'm looking at kind of this standpoint of like, if they're on like day 2 and they're going to get worse, I want to know what they are. I want a set of eyes to see them at their worst and whether they need to be inpatient or not. If they're in the inpatient setting, we treat their symptoms. Okay, so if they're dehydrated, we'll give them fluids. They'll be on IV fluids at that time. If they need supplemental oxygen, you have a range between nasal cannula, so you can just get like 2 liters through your nose, all the way to, we can use something called high flow nasal cannula, which gives them a little bit of pressure and is really high flow and a lot of oxygen. And then sometimes kids do need to be intubated. If they're having any hypotension or signs of sepsis, we can go to vasopressors, and sometimes kids do need to be on ECMO. So ECMO is, depending on the mode of ECMO, there's something called VV ECMO and VA ECMO. So whether the ECMO serves as your heart to pump your blood through everywhere, or it could be your heart plus your lungs for oxygenation and pumping of the blood. So quarantine. So a lot of the times when I discharge patients, I need to, and if they're not positive, a lot of times parents will send their kids into the emergency department just to get tested. So if they're in a close contact with a patient within 6 feet of prolonged duration, greater than 15 minutes in a 24-hour period with someone with COVID-19, I was trying to kind of define quarantine is if you've just been in close contact, but you're not positive. You don't need a period of quarantine if you're fully vaccinated and asymptomatic, but you want to get tested 3 to 5 days after the exposure. So if you just realize that, hey, yesterday someone was COVID positive, if you get tested, you may have a false negative, just because you don't have enough viral load for it for the test to be positive. You should wear a mask in public for 14 days until the negative result, and then isolate if you develop symptoms. So you want to stay home for at least 14 days. You want to watch for symptoms, so fever, cough, shortness of breath, and other symptoms, and then try to stay away from people that you live with. I know it's very hard for kids to do that, right? So they depend on another caregiver a lot, but we try to keep them in a separate room and separate bathroom. You can shorten the quarantine based on state and local guidelines. So you can, if you're asymptomatic, after day 10 without testing, and then after day 7, if you received a negative test result, the test must occur on day 5 or later. And these are CDC recommendations. Isolation is when you're separate from infected people, or is for people who are infected, and it's not quarantine. And you're separating from people who are not infected with COVID-19. You stay at home until it's safe to be around others. You're separated from others that they live with, so a specific room and bathroom, and then avoid sharing towels like cups and utensils. And you want to monitor for symptoms, right? And so seek medical attention if necessary. So if they're having difficulty breathing, they should probably be seen by a physician. And especially if kids have underlying asthma, they may need some steroids as well for the acute asthma exacerbation. So discontinuation of isolation. So they have a COVID-19 infection and symptomatic. It's 10 days since the symptoms first appeared, and then 24 hours with no fever, without the use of fever-reducing medications, and then other symptoms of COVID-19 are improving. So that's true for any other viral illness, that we want them to be at least afebrile for 24 hours without having to continually medicate them with either Tylenol or ibuprofen. And then they are asymptomatic with a COVID-19 infection. You want 10 days from the positive viral test. And then they have to move to the above recommendations if they start having symptoms. So prevention, CDC guidance for COVID-19 prevention in schools. They want universal masking for kids greater than 2 years of age while indoors. Try to social distance for at least 3 feet when possible. They want universal screening, some respiratory etiquette, meaning they cover their mouth when they cough and they have their mask on. They are staying home when symptoms appear. having good ventilation, hand washing, and disinfecting cleaning surfaces. And Dr. Kazi will further go into that topic in the next lecture. So vaccinations, we know that they work because there's high rates of infection in states with low vaccination rates. My home state of Texas, Louisiana, Mississippi, Alabama, Georgia, Tennessee, and Florida. And then the CDC and AAP, the American Academy of Pediatrics, recommends COVID-19 vaccination in all eligible children greater than 12 years of age. And Pfizer is submitting a emergency use for kids between 5 to 12 years of age for their vaccinations. When is a person fully vaccinated? So 2 weeks after their second dose of a 2-dose series, or 2 weeks after the single dose vaccine. So the Johnson & Johnson is the single dose, and then Pfizer and Moderna, the two-dose series. So conclusions, pediatric COVID-19 infections can range from asymptomatic to hypoxemia and heart failure requiring ECMO. So it's a big spectrum, right? That's a wide range of, you can go home, you're fine, to you're really sick. Supportive care is a cornerstone of treatment. And then MISC is a Kawasaki's-like illness, so persistent fever, myocarditis, GI symptoms, and rash. These are my references. Some good references to use is healthykids.org and the CDC for recommendations. They're the most up to date.